All right. The bald men are back.
The Baldies.
We're back for episode 30. So
Is it 30?
It's 30. We are 1 week
One.
closer and one episode closer to being pain free at 100 years of age.
We're almost 33% of the way there. We're 30%. Check my math on that, but I think I'm right.
So what's been happening, Dr. Mike?
Nothing. Things picking up in the clinic, trying to buy an apartment with all that beautiful fun, try to plan a wedding, trying to do everything, survive the snow. It's a beautiful New York City existence I'm living. So I've got no complaints. I'm enjoying it. I'm enjoying the process of building. How about you?
Good. Yeah, same sort of grind, I suppose. It's early in the year, so there's a lot of change happening, getting the clinic up and running, so I guess implementing a lot of the things that have been in the pipeline for a while, which is awesome and scary all at the same time. It's all of those things that were always like far distant kind of ideas that you sort of go, I know I've got to do that, but I don't need to think about it right now. Well, now I do need to think about it, and now it's happening.
Now it's game time, baby.
Yeah.
Welcome to the life of like panic. 3 a.m. wake up and you're like, oh, I've got to do this, and then trying to convince yourself that it can wait 3 hours before you wake up at 6 a.m. in the morning. So yeah, I wouldn't have it any other way. I'd rather do that than rely on somebody else to provide me with the funds to eat.
Yeah, well, I've done that too. And I guess this is a different responsibility, but it's got that extra level of, I guess, enjoyment about it because you're getting to express your own ideas, which is cool. So I love that.
Yeah, being a small business owner, you are, like my fiance Brianna always jokes about it, and she's not home, so we can talk as much as we want about her today. She's always like, I thought I was gonna marry like a New York, Williamsburg, Brooklyn creative type person, and here I am. I'm engaged and going to be happily married to like a science, math, engineering, mathematics kind of guy. And my response to that is always, the level of creativity that it takes to successfully run your own business is absurd, right? It's something that you don't consider probably when you open things up, but just the ability to creative problem solve, it just happens in infinite iterations on a day-to-day basis. It's just everything needs creativity. And sure, I'm not sitting there in fucking overalls and a beanie and a flannel, painting a picture or writing a song on a ukulele, but I'm certainly, and you can attest this as well, it's all about creativity. It's mostly creativity, and then there's basic mathematics skills and then your technical skills from a physician. But it's, if you have a rough day and you're not thinking clearly, you're not going to come up with any creative solutions. So it's Brianna, congratulations, you've married a creative in New York City.
Yeah, I think one of the big things that I've found too is to really kick that process along is just talking to peers and making the effort to, share ideas with people. And a lot of that, comes out of discussions with you and some of our colleagues and even friends of mine that are business owners that are in completely different industry, but having conversations and running ideas past them for feedback and stuff like that, that has been super valuable. I've brought across a lot of ideas for things that make complete sense, but I didn't come up with that idea myself. But I wouldn't, and I may not have. It's just it's an awesome process. So I think having a really tight network around with some good resources is invaluable.
Yeah, and that the sense of your creative sense improves. It's, obviously people have a genetic baseline, as they do for everything on this planet, but your creative sense can be honed and it can be improved and your efficiency can increase, and it's just like any other skill. And I know you think similarly to me, and every time I walk into a business, I'm stealing ideas. I'm thinking, if this was, if I was a fucking baker, what would I do? If I was a fucking, if I was Mike the barber, how would I approach this situation? Not that I need a barber per se, but, walking into a business like that, and you get a feel for it, but it's not necessarily a natural thing. And it's fun. So to sort of wake up at 3 a.m. and conquer one of those problems, it's like having two dicks. Right? Like you get that empowering feeling. Waking up at 3 a.m. because your boss is pinging you, from Microsoft Teams to do something, you don't derive that same satisfaction. So I wouldn't change a damn thing. I wouldn't change it for the world.
Yeah, I'm with you. I never want to be woken up at 3 a.m. by a boss pinging me for something. That sounds terrible. So we need to bring this back around and start talking about some joint health again, right? We've had a couple of really cool episodes, but I think it's time that we loop this back around and we start helping people be pain-free at 100.
The COVID chronicles were fun, but we got to move back.
Yeah, absolutely. I'm having my own kind of thought process around being pain-free at 100 at the moment, and it's nothing new. We've talked about this before, but I have some new insights, I suppose, into this at the moment. So I took myself recently, I referred myself to get an MRI on my low back because since I had the surgery 3 years ago, I'd had a follow-up x-ray since then. And we know like x-ray is helpful, but it's a little bit limiting in terms of what we can see. And so I wanted to have a good look and see what's going on. I knew that I probably should have done this sometime a little bit earlier, but I hadn't done it. For whatever reason, got too busy, made enough excuses. So I booked it in, got it done. And I wanted to match this up with some mild symptoms that I've had lately that had just been annoying. And I needed to understand that a bit more. And I guess I needed to understand what is the reality of what's going on right now, because I'm getting closer to being 40, which is still a long way from 100. And I need to know what are the things that I need to change now about the way I live my life, or I just need information. I need to know what to do so that I can be pain-free as I get old, but I want to be functional. I want to be a functional father and partner and husband and all those things in the future. So that's what we did. We went and got some imaging. So I thought it would be cool to share that report with you. Now, you haven't seen the images, you haven't seen the report yet. So I'll give you a little bit of background about the symptom set that's kind of been annoying me a bit lately. And then I thought we'll just pick apart the report, it maybe in the context of a patient of ours, for instance, that would get a report, because you get these reports and they're pretty technical. And sometimes there's some scary words in there. And if you don't really know how to interpret that, it can be quite daunting and it can be quite worrying as well. If you've got some pain and you see this report with all this stuff on it, it can kick your stress levels up for sure. And sometimes you see that on people's face, and it takes a little while to kind of explain what all of this means. So I thought, why don't we pick some words out of this? It's a common thing for a lot of people to have, that lower lumbar L5S1 problem. Let's see.
Yeah, I mean, this is like, one of those catchy YouTube videos, like joint health doctor blind reacts to an MRI. But, in all seriousness, I'm going to treat this as if you're my patient, Chris, right? You're walking in and just to give people an insight as to what we look for in MRI reports, how we take that and reflect it back onto what you're feeling clinically, right? Because we've all had patients that have had, jammy ass MRI reports and it doesn't necessarily clinically correlate. We've had people with jammy ass MRI reports that have really high lower back function and what that means to people. So yeah, let's take a look at this thing and let's break it down from a fundamental standpoint.
So just to give you a little bit of the clinical indication, the surgery that I had was 3 years ago. So they removed the extruded disc material
At L5S1.
at L5S1, and
Okay,
that
but
had
there's
been
still some disc there, correct?
yes, yeah, a little bit. So that had been compressing the left S1 nerve root. And so that
Okay.
was I guess that was the big issue that I had, which is why I landed there, because there was motor weakness and all this stuff.
Was there sensory deficits?
Yes, there was.
Bottom of the foot or whole dermatome?
It was, I guess, the lateral part of the foot, so the little toe. And also up the back of the hamstring. So it was more kind of S2. And that hasn't come back. That's still, to this day, that is still numb. The little toe is feeling is through there, although it's reduced. And so what I'd been noticing over the past probably few weeks is that I was getting numbness in that little toe. And it was quite obvious. I'd sort of stand up, I'd walk around a bit, and it really just felt completely numb. And it'd be a little bit intermittent. It'd come and go, but it was constantly intermittent, if that makes sense. So over the course of 3 weeks, it just wasn't going away, which was enough of a flag for me to want to know what was going on. And I was also getting some fasciculation, so some flickering of the muscles in the lower part of my leg. So the calf muscles would sort of flicker and cramp a little bit. And it was just a bit unusual. There was a little bit of numbness around the around the area where your Achilles tendon is, so the bottom part of the leg. So it was all still kind of fitting with that pattern of the area that had been injured, but it was just a little bit too consistent for me. I guess over the past 3 years, you get a little bit of that from time to time. Maybe some inflammation flares up in there. But this was just occurring consistently enough that I wanted to have a look and see what's going on.
Okay.
All right.
So just from that, right, you're hearing that in a history. You haven't necessarily taken a look at the MRI. You've got the MRI in your back pocket, in your file, whatever. You're looking for, when you have deficits that strong, when you have motor deficits seemingly in fasciculation and or motor interference, you've got sensory deficit that's starting to kind of flare up a little bit. You're looking for anything space occupying that's actually going ahead and touching that nerve root. Now, we've removed an extrusion, so I'm already a little weirded out thinking, okay, how much disc material is really left in that disc to where we could have, a volume of a herniation, protrusion, extrusion that actually is space occupying on that nerve root. So let's see what we got.
All right, let's pull the report up.
Let's pull it up.
All right, here we go. Have you got that one?
I've got it.
All right, so let's walk through it. So it's an MRI of the spine. The clinical history they've noted, so L5S1, laminectomy, discectomy in 2017. So what that is they've opened up at the spinal level at L5S1, and to remove some of that disc material that needed to come out, they've done a laminectomy. So that's cutting away some of the bone to actually get into the area where they need to remove it. And the discectomy part is removing the disc material. So the sagittal, all the T1, T2, all that stuff that you see there, that's the different types of images for looking at different structures. So whether you want to see more fat, you want to see more water. And then we've got the findings. So Dr. Mike, do you want to step through the findings and then we'll have a look at each one?
Yeah, I mean, prior imaging unavailable for comparison. Normally what you do want when you're doing follow-up MRIs like this is you'd like a before image, just to see as a comparison. It shows you a little bit more because these are just instant snapshots in time, right? So at least if you have two photos that are easily comparable, you can kind of put things into motion a little bit, right? It's like a motion picture. You can build a little bit more of a movie. So you've got a sliver of T2 stir hyper intense fluid at the L5S1 laminectomy. So you've got some fluid buildup there.
Yeah,
and that's reflected by a hyper intense signal. So fluid is going to really flare up, right?
Yeah, I've had a look for this on the images and I can't find it. So we might have a look at that later. But yeah, I'm guessing there's some inflammation in there of some type.
Bruising. Right? I mean, you can bruise in your bone, especially if you're post-surgical. Modic type 2 L5S1 disc degenerative changes. So we look at that and we say your disc is degenerating, right? That beautiful, nice, puffy marshmallow of a disc is has already changed and is degenerating, and you're getting a disc space that's typically this large, and all of a sudden it's flattening out this way, which makes perfect sense, right? Given your history of trouble at that level, and then you're removing part of your disc, so makes sense as to why there would be degenerative changes. Your conus medullaris terminates normally at L1, L2, no significant facet joint degenerative changes. So that was something that when we're talking, I'm looking for something that kind of flared up in my head. We've got, what kind of facet changes are happening? We knew that you weren't getting a lot of deep, achy, sclerotogenous pain. It was more radicular neurologic pain. So I'm like, probably not a tremendous amount of joint degeneration from, a facet standpoint. And even we know that the degenerative changes from the L5S1 disc is not likely causing a tremendous amount of your symptom set.
Yeah, what's interesting is that we're going to get to the disc and you'll see that it is extremely degenerated, and you would expect it to have a fair bit of pain just reading this, but that's not necessarily the case, which is interesting to give some context to this, right?
That's always why the symptom set, right? That's always why you take that beautiful history, because you might get this walk into your office and you may only have this first finding. And, that might be a terrifying thing to hear. I mean, it's impossible given the fact that, your neurological radicular symptoms, but, this is not a pain driver according to your history and the symptoms that you're presenting with. And we'd go and we'd reflect that back with an exam, and we'd, cross our T's and dot our I's. Sorry, my dog is like running around underneath me. A little bit distracting, but this is clinical life, right? We'd cross our T's and dot our I's and just make sure. But to me, it's not likely that this is causing it. And we're going to find the pain driver because we can all read, and we've probably continued to read on during this report.
Yeah. And look, the other thing here is the modic type 2 change, which was new. So that wasn't a feature of the MRI that I had, which was like the day pre-surgery. So for me, it just, I guess what's modic type 2 change? So essentially there's some inflammation in the vertebral body, so in the bone. So the disc has degenerated so much that there's been fluid that's escaped through the end plates that normally keep that nice hydraulic state within a disc. And you can see that on the images now. There's actually there's inflammation in the bone and edema. So that to me just kind of highlighted that degenerative process has continued to move forward in the past 3 years. So I guess I didn't love to see that again, though, even though it's not necessarily causing pain right now. It just it is what it is.
I mean, I'm curious to see if had you done everything perfectly, right, would that change be there? Is that purely a result of somebody cut your bone out, right, and your support system has been functionally removed at the expense of reducing your radicular symptoms, but you don't get something for nothing in medicine. And when you go in there and you cut somebody's lamina to get at a disc to reduce a pain driver, right? Is that just inevitable, right? That those end plates are going to start to break down, that edema is going to happen. And again, you're like you said it really, really perfectly. You're kind of losing a little bit of that hydraulic stability, right? You know, a piston, if we look at a piston in a car, it's perfectly parallel on top, perfectly parallel on the bottom. And as those end plates start to change, right, you're going to lose that structural integrity of the actual piston. So again, I don't have enough experience. I haven't been doing this for 40 years to know whether or not that's just inevitable, but it makes sense, unfortunately.
Yeah. So I think it's just one of those things that I want to track a little bit, which I guess we'll we might get to that what's next kind of thing, but that's something that I want to put a pin in. So let's go to the next line. So we've said the conus terminates normally, so that's just essentially the spinal cord terminates at the level it's expected to. It's not interfered with at that stage, and there's no significant joint degeneration that you mentioned, which is good, because I thought potentially, a few years of running these disc degeneration down here, there's going to be extra load on the facets. Maybe we'd be starting to see something there, but that was nice. So there's a positive.
We'll take it. Yeah, and that's it's unusual with the modic end plate stuff, right? Like it doesn't make sense that in the absence of surgery, in a complete hyper-isolation of your condition, like who has modic type 2 end plate changes and not facet degeneration? So that to me is a little bit more indicative of like, hey, you had a laminectomy, and that just might be the nature of the beast.
All right, next line, Dr. Mike. So we're really getting into the weeds now.
Into the weeds. Posterior central disc protrusion causes 30% central canal stenosis. So you've got a disc herniation, or excuse me, protrusion, not a herniation, which all the same shit to me if it's not an extrusion. 30% central canal stenosis. So we're looking at a disc herniation that's not herniating out into a nerve root. It's herniating out into the central canal and ultimately cord, right?
Yes. Yeah. So I guess the probably more common types of protrusions that we see are a little bit more out to the side. So it'll kind of be a posterior lateral. And that's where, as you mentioned, you usually get that nerve root on one side. With mine, it is a little bit more to the left. Mm-hmm. That's where the bulk of the protrusion is. But so it does pick up or at least it did, and I think it still does a little bit based on the image, but it does pick up the S1 nerve root a little bit, because that's the one that's going down. It's descending. So when you get those big posterior ones, they generally are going to cause some problems there. The thing that stood out to me, I think that I hadn't seen on a report before, was the 30% canal stenosis. At close to 40 years of age and wanting to be pain-free at 100, it's not what you want to see. But there's plenty of room there still. So yeah.
Yeah, I mean, you're not looking with that. And again, as long as you're aging gracefully, aiming to be pain-free, fully functional. At 100, that's not a death sentence. It's not like you're crushing your motor roots and things like that. It's definitely there, and it's definitely something that clinically correlates to your condition, which is, that's the thing that is, blinking red lights at me. And how much of that we can reduce is going to largely be determined on how much adhesion that we would actually find in your lower back, right? I mean, do you have severe adhesion can be reduced? Then, I don't necessarily know if it's going to go from 30 to 15, but can we get it to be 30 and to stay 30 and to get a little bit of that symptom set to go away? I would certainly believe so, depending on what we actually find in palpation.
Yeah, and that's where this is interesting because, of course, I've been thinking a lot about what are some things that I can do to try and move the needle on some of this. So we can get to that later. But, I think this is good to have this baseline now because it does give something that we can reference in the future. All right, so we've got some annular tears in the disc. So we've got posterior, marginal, anterior, and central annular tears in the disc. So,
is there any other direction?
No, it's just basically just
marginal, central,
shreds.
anterior. Yeah. Okay, maybe we don't have any lateral tears.
So the annular tears, for the listeners, this is where you've got the disc, which has got an outer ring that's ligamentous, with the toothpaste in the middle. But this outer ring is where you get these tears. And this is what hurts. This is when you get really severe acute back pain, and you don't necessarily have a big bulge or protrusion or herniation or anything like that at that stage, but it's painful, and you can see it on the MRI, and you can see one on mine, and I've got a boatload of them, and I'm not in pain. So again, that clinical history is really important for this.
And those annular tears are what, if you're a loyal listener to the podcast, first of all, thank you. We'll send you a t-shirt or something after we make them. But these are what we would typically consider, colloquially as disc irritations, right? The thing that hurts for a week goes away. I blew my back out. I slipped the disc. I did all that stuff. This is, and you can accumulate a substantial amount of these and still have a relatively healthy disc. It's best practice to take care of them as soon as possible to prevent them from going and re-tearing and actually tearing more. And that's when you're going to start to get some of those bulges, herniations, protrusions, extrusions. But this is typically what we mean by a disc irritation. And again, we know none of these are hot because you're not in that kind of spastastic pain. So again, while those are there, and it's great to have that picture of a snapshot in time, this isn't something that I'm hyper concerned about from a clinical standpoint, in terms of how are we going to get Chris A to reduce some of those kind of peripheralizing symptoms and B, age gracefully.
Yeah, these have got, I guess probably no effect at all on the stuff that we've been feeling in the leg. So it's there, and we kind of acknowledge it, but at least at the moment, it's just kind of noise, I think.
Yeah, it's an indication that there's too much compression there, as is everything that we're going over here. It's just, you're drinking water out of a fire hose right now. Like,
well, I could reduce it down just to my first thought when I looked at this was just, oh man, this disc is fucked.
Sure. Oh, it's certainly fucked.
That was my first thought, just to I guess sum it up. But yeah, on top of that, we've got an anterior left-sided disc bulge and desiccation of the disc. So the disc is just dry. Normally these discs are, like Mike's talked about, they're sort of fat. They've got water in them, and usually because this is the lowest disc in the spine, it should be the biggest. It takes the most compressive load, generally does the most work in terms of our bending and hinging and flexing. And in my case, it's probably the smallest. It is the smallest because it's lost all of its goo. There's nothing left in it.
I hate when there's no more goo left. And again, this isn't something that's tremendously clinically relevant to you right now either, given your current presentation. A lot of this stuff is stuff that we don't want to continue to progress, and we're going to work really hard to prevent that from progressing. But in terms of, accurate diagnosis, what is the pain driver in this situation? And, we know it's that posterior central disc protrusion.
So we've got, I guess, a summary of the other levels to wrap it up. So they've mentioned that there's no significant stenosis of the central canal, the recesses, or the neural exit foramina at other levels. So they've looked at the whole of the rest of the spine and said, you're in good shape there.
Yeah.
You've got one level that is a nightmare.
It's pretty messed up. But.
And so looking at the images, I guess for me, that was quite relieving in a sense, because you do actually see that the one above, so the L45, the disc is just a little bit darker than what you'd want it to be, I suppose. So there's a little bit of extra work going on there. That's probably just starting to show a little bit. But on the whole, the rest of those segments look really good. They look really nice and clean, and that's great. But we've just got to manage this other one.
Yeah, and that's why. And again, when people come into my clinic, I always ask for the reports. I need the reports. I'm not a licensed trained radiologist, so I'm not going to be able to look at something and really get into the weeds of it. But I still like seeing the images, because there are things that I look for that perhaps a radiologist at an imaging center may not deem clinically relevant. So you just mentioned a perfect case right there. Is we're starting to get a hypo intense signal happening at L4, L5, which is letting me know there aren't maybe not be changes that are going to flag a radiologist per se, but it's something that at the very least I'm bringing up to you and I'm saying, hey, L4, L5 is going to turn into L5, S1 if we don't take care of this. And there's nothing closer to the truth.
Yeah, pretty much. I guess that was one of my fears, was that I was going to look at this and see that it was maybe a little bit worse or something like that. Because you just don't know till you get eyes on it. But yeah, for the moment, looks pretty good. So tick.
Tick. Yeah, I mean, that stuff looks good. You got to figure out a way to make sure that 30% doesn't start to progress.
Yeah. So, I mean, that's the thing. I think for me, that's the big finding in all this. They've sort of concluded there's no drainable collection. So that's to do with that, the fluid that they identified. And then they've just pointed to the posterior central disc protrusion, which is causing the stenosis. So, that's the big daddy. That's the big finding there. I'm pretty confident that, the irritation that is going on there, that's been going on for a long time, is still responsible for the symptoms. Looking at the images, it is more on the left-hand side. And it actually looks a bit like there's a bit of swelling to the left nerve root. And look, I'm not a radiologist. I just I guess I'm more of looking at it from my own sort of nerdy perspective, but it does look a bit swollen, a bit fatter. So, I think that's probably been some chronic inflammation there for sure, which is causing some of this stuff, rather than like a hard sort of compression.
Yeah. And you always got to say, what's the exam say? Is your lower back 60%? Is it 70%? Is it 80%? Is it 100%? What's your sciatic nerve moving like? Where, what movements are causing you to experience more numbness? What movements are causing you to, hey, maybe that's reducing it a little bit. So it's building that picture and determining, what we can do from a prognosis standpoint. And then obviously, we know that keeping your adhesion low, managing load, sleep, diet, stress management is all what's going to be needed in order to get that to the rate of degeneration to slow down. But there still may be an area of opportunity here to where we can get things to move better, right? Can we get a little bit of that chronic inflammation to go away by getting your joints to move better? Can we, and again, I'm not sitting here saying we're going to take a 30% central canal stenosis and turn into a 15, right? Or a 10 or anything like that. But can we get a 2 or 3% change that may not even show up on an MRI for 3 years from now? And in that 2 or 3% change, that's going to have an exponential effect on your symptom set. So, get rid of that inflammation on the nerve root, make sure that everything else is as healthy as possible. And again, we might not get a tremendous amount of motion at L5S1 because you've had surgery there. And this is all, painting the picture of what Dr. Chris's back is, right? Your lower back is a Monet. And I say this to my patients all the time. It's a picture that, we can see what it means when we zoom out, but only after we, paint each individual brush with colors and shit like that. I don't know how fucking Monet painted, but we know that there's all crazy. There's purple in grass and stuff like that. So that's what we're doing. We're zooming in and getting every piece of that puzzle. And then we're zooming out and taking a big picture look at what's happening and building your prognosis based on that. You came into my office and you had moderate adhesion. I'd say, yeah, maybe we get a 10 or 15 or 20% reduction in symptoms. And that may be enough for you. It may not, right? You may say, that's not enough. And I'll say, okay, that's fine. That's all I'm promising you. And then I'll say, this is only going to get worse as this progresses. So at the very least, and my last pitch to patients in your situation is like, hey, at the very least, we're going to make you age gracefully. And if that's something you're interested in, then let's get after it and reduce this adhesion. And if not, good luck.
Yeah, this is where I have to, I guess, take a step back and take my practitioner hat off a little bit, and go to other people for help and just kind of let them be the experts. I'm going to feed into that process a bit, but I think it's I need to rely on other people a little bit here to look at it through their lens rather than my own biases. And so I think there is an opportunity to clean up I don't know how much, but I think there is going to be something there just to decompress this area a bit. And I need to be more consistent with that. I think I probably haven't done enough in the past few years. I've gotten myself to a point where I can be pain-free in my living, and I'm functional and I'm happy with that. But then once I get this new view and this new information, I think it just kind of puts context around that and goes, yeah, you're not done yet. You need to actually, you need to do some more cleaning up here, because it's not about the right now. It's about the later on. And so I think, for me, this is going to be something that I'm going to have to do a little bit more intensely starting from now. And I'm going to have to maintain a pretty rigid schedule, I think, a bit like going to the dentist and getting plaque cleaned off your teeth, because it looks like a bomb has gone off in there on the MRI, and that is going to lend itself to creating more adhesion and more crap in there that is going to need to get cleaned up. So I need to take my own medicine, and I need to actually get out, and I need to make the effort to get on top of that more regularly. Yeah, it's just got to be done.
It does. And you've got symptoms right now too. So let's not forget that there are very real things happening now that perhaps weren't happening 3, 4, 5, 6 weeks ago. So it's not just hey, let's go remove the plaque that builds up after, 4 or 6 months of not seeing a dentist. My dog is crying, but you've got a cavity. Like, you need a crown, you need a root canal right now functionally. And then it becomes, okay, we've fixed your tooth. Now we've got to do the bare minimum in order to make sure that you don't turn into, I don't know. Do Australians have bad teeth like British people? I have no idea.
British are way worse.
British are way worse. All right. Yeah. So you're not looking like somebody from Liverpool or something like that. So,
yeah. So I think that's like the next phase, is to get that hands-on work. What's up, Juno? Juno's joining the podcast.
She's crying right now. Keep going. We're good.
I'm going to have to go see Dr. Marcus. I'm going to get some work done, and I'm just going to have to let him do his thing, let him take over, and let him treat what he finds, and just be the patient, which I'm looking forward to. But then after that, and I've organized this already, but shout out to my good buddy Nick, who's an exercise physiologist. He does listen to the podcast. God bless him.
Truly. God bless you.
Look, he's fantastic with his approach to rehab and assessment and human movement. And so, I'm just going to rely on him to run me through his lens and see what he finds and see what opportunities there are to improve my movement and positioning and strength, and just see what we can do, because I would like to think they might only be small things. We'll find out. But, if we can grab a few of those things and work on that, then that might be that 2 or 3% that you talked about. And if we put that with maybe something that Marcus can work on me and decompress the area physically a little bit, maybe that turns into 5% over a long period of time. And it doesn't sound like a lot, but symptomatically it might turn into a big deal. And certainly over a long period of time, it's a big deal. So that's the plan, I guess. I just have to take my practitioner hat off a little bit and let people do their job.
That's it. Let people do their job.
So, look, I hope that is a little bit informative today, because, I must admit, when I opened up this report and had a look at it and read it, I had that oh shit moment, and it's a little bit scary, some of the words that come out of there. And that's coming from me being someone that knows how to interpret this stuff. But when it's your own report and it's on your own body and it's giving you information about things that you didn't necessarily expect, it's a bit worrying. And, you can amplify the shit out of that in your brain. And it just depends what sort of state of mind you're in that day. But, it can be stressful. And, for people that have chronic pain and perhaps get this image like this, and it comes back with a whole lot of stuff on it, you keep seeing this word degeneration all over the place. It can be quite stressful. It can be quite worrying. But, we have to kind of pick it apart, and we have to look at it and pick out what's really relevant to the current situation, what's relevant to the future, and then put it all in context of that person. So I hope that helps a little bit based on my crappy report.
Yeah, just a little insight into what we think about what we see, what we look for, and how we use an MRI to build a clinical picture.
All right, folks. Well, that's episode 30. We're almost a third of the way to being pain-free at 100 episodes. So we'll continue on. Any final thoughts, Dr. Mike?
I do not. Any final thoughts, Juno? Nope.
Nothing from Juno. All right.
Nothing from Juno.
We'll see you guys next week.
See you guys.